Hello and welcome. Some 30% of patients, according to a report in a Johns Hopkins medicine journal, hospitalized in China and New York, developed moderate or severe kidney injury symptoms. That's point number one. Point number two, a city like Mumbai now is facing increased number of cases and pressure on hospitals, not just with the normal cases of either simple or moderate symptoms, or for that matter severe, but also complex cases which involve kidney injuries like the ones we just spoke of. So to what extent are these twin challenges affecting this city and their doctors and affecting their ability to respond to patients who are affected by COVID, and how should we be looking ahead as cases continue to rise? To discuss this, I'm joined by two expert doctors, Dr. Siddharth Lakhani, consultant nephrologist and transplant physician at the Fortis, Raheja and Global Hospital, and Dr. Gunjan, Chanchalani, chief intensivist at the Bhatia Hospital in Mumbai. Thank you both for joining us. So let me get a broader perspective first before I come to the nephrologist point of view. Dr. Chanchalani, what are you seeing in terms of cases and patients that have been admitted in the last 45 to 60 days, and what's been changing, if so?
First of all, thank you so much for having me here. I work at Bhatia Hospital. So when we started with COVID, we started this planning early in March, when with the first case that was reported in Mumbai, or in rather in the country, when they were screening the patients who are people who are traveling from abroad. So that is when we started the whole planning about having Bhatia being ready for taking COVID patients. And we had multiple mock drills and everything. The main scene of these patients started around the second week of April, you could say, when there was a surge in seeing the number of patients who were coming in. Let me tell you, COVID is no different from any other illness that we have. The thing of COVID, the mortality is not very high. If the patients do reach on time, they do survive well, and many of them are asymptomatic or mildly symptomatic. The panic here is the infectivity. That means which is the infectivity or the R factor that they call it. So when the R factor for COVID is very high, that means a single patient can actually infect many patients. So this is what is overwhelming our healthcare system. And this is where the problem is coming. The problem is not about the COVID disease per se. It is not very
Right, but that's a good point. You're saying that people who come early to you are largely getting treated. Are you able to put an approximate number to that?
See, if you honestly ask me, in the month of April, we were quite balanced with our resources. If I'm very clear about this, we were quite balanced with our resources. We were able to take in every patient who came to our hospital. But you could say from early May, since the number of cases infected have increased, we have to turn away patients from our hospital. So that is one sad part, because our resources are not able to match to what is there. And the resources is not really the space. The resources is mainly the manpower resources. Because when a staff enters inside with that kit, it is very difficult to function for more than 6 hours. And to decrease the infectivity to that staff or the risk to that staff, we have to give them a 7 days wean-off period or away from the virus period. So we can't make them work alternate 7 days. So it is a big factor for the healthcare worker. So our resources are actually come down to 1/3 of what they work. So 50% staff is off on alternate weeks, and we initially had 3 shifts of people working. Now we have 4 shifts working. So you can imagine how much manpower resources we are falling short of. So this is the time when the cases have increased. We are falling short of manpower resources more than the space resources.
Right, but you are saying that for those who are turning up early, and this was a problem particularly last month when, let's say, the average time, as I understand from reports, was 3.5 days. Now it's come down a little. But if people are turning up, then you're saying the ability to respond is almost like any other maybe disease condition, almost like a flu, if I'm not simplifying it too much.
See, the condition is, yes, definitely like a flu. But now we are turning away people because we are falling short of beds or people to take care of those patients.
Sure.
So we have beds, we have beds, but we don't have people to man them.
Right, understood. Right, Dr. Lakhani, how are you seeing the progression from your point of view as a nephrologist? Are you seeing similar trends as been reported by this Johns Hopkins medicine report amongst patients in New York, or for that matter in Italy and even in China?
So yeah, thank you so much for the invitation here. So basically, when we started, as rightly said, when we started in April, the cases were much lesser. That time, the suspect load was much higher, and the positive cases were much lesser. So it was because we didn't have much of the patients with COVID reports, and that time all suspects we were able to manage them, admit them, because the beds were much sufficient. And when it started, that time also, starting there were lot of issues with Mumbai. A lot of dialysis patients were having problems because there were very few centers who were able to do COVID positive dialysis. Then slow and steadily, we started realizing as a team all over Bombay that probably we'll need more and more machines. So slowly with time, definitely we are coping up. Now, last probably Nair itself has crossed 100 patients, 100 positive patients today we have crossed in Nair itself who are newly diagnosed, probably are newly admitted with COVID and they are getting dialyzed there. Seven Hills definitely has a significant higher number. Machines which were much lesser at Seven Hills, Nair earlier and KM. Now we are able to do it at multiple places. A second part is earlier we were doing all indoor or IPD patients only with dialysis. Now we are having isolation centers or probably dialysis centers, standalone centers which are catering this positive COVID who are asymptomatic. So definitely government has been realizing with time that all COVIDs who are probably asymptomatic doesn't need admission. So now guidelines have changed and probably still with time we'll realize that even mild symptomatics will have to be managed home only if we really have to salvage the others which are severe.
Right. And many countries are doing that. And I'll come to that in a moment. But tell me, when you say machines, you're obviously talking about dialysis machines. So these are patients who were already having some kidney ailment, or these are patients who have developed kidney ailments after contracting COVID?
So we have both. Definitely more number of patients at present are dialysis who are COVID positive. They were already on dialysis because being immunocompromised, and secondly, they are the ones who are going out daily on a weekly basis, whether it is twice a week dialysis or thrice a week dialysis. As rightly said by the intensivist, that critical patients, the numbers are very less. If you see really, they are going to be either they are coming with severe cytokine storm, with severe DIC, or probably landing up into severe multi-organ failure. This patient, the numbers are very less. We may be seeing them probably out of the admission, probably less than 5% of patients are having this type of picture. There are patients who are already having some or the other kidney ailment. And because of this excessive stress or probably because of this viral illness, some patients are landing up on dialysis because they were already probably a chronic kidney disease patient. And because of this stress, they have landed up onto dialysis.
But are you seeing cases where, let's say, people are coming with COVID-19, I mean, people have been tested as COVID-19 positive, but the symptoms are only those of some sort of kidney damage or kidney failure? As in, so the question is, are you seeing, in contrast to, let's say, people who maybe in the early days were coming in with lung infection and respiratory problems?
So only what we have seen is few patients have come with proteinuria to start with. Not all patients who are asymptomatic or mildly symptomatic having a rise in creatinine or probably a poor kidney function. What we are seeing is, though they are premorbidly healthy, young patients also, we have found few patients to have proteinuria on the routine urine reports. Definitely with time, we'll have to know that probably whether this was a previous proteinuria report which was positive or they are having persistent proteinuria. Specifically, kidney affection or rise in creatinine with COVID illnesses is very less.
But what does that mean, doctor, in your understanding? So does it mean that this virus is now maybe attaching itself to receptors in the kidney, as they say it attaches itself to receptors in the lung?
Probably it is the effect of interleukins and cytokines which is going and affecting the endothelium, and that is how it is causing proteinuria. So it is the same pathophysiology like it is affecting the lungs, or it is affecting the myocardium or the heart. That is the same way it is affecting. It is because of these markers or because of these inflammatory markers which are released because of the illness, not specifically the virus specifically going and affecting the kidney. Foreign literature, they have shown some histopathology reports, but in India per se, we still don't have a specific pathology report showing affection directly of the virus to the kidneys.
Right. And I mean, this is obviously a very difficult time for patients who are already suffering from some kidney ailment, have to go through dialysis, and many have to go through dialysis I'm sure in some cases almost every day or every other day. So how are these patients managing?
So at present, as I said, now almost we have around 12 centers which are managing in-house dialysis patients for these COVID patients. And we have come up with Project Victory since last around 5 days. And this Project Victory includes basically a live count of machines which are available for these patients, where the hospital and the patient both are getting registered. And the moment the hospital has a COVID positive slot empty and you have a COVID positive patients waiting for dialysis, they are directly directed there. Initially, this was a problem that a lot of patients were rejected, a lot of patients were running here and there. that they were not able to procure a bed for dialysis. But now, because I think with this project, we are having a lot of easy things, because patients are able to know where they have to go. Because entering a casualty or an ER department and then running down to admission was a real difficult, challenging task for this patient. So now they know they have to go to this hospital and they are already registered there. So it becomes easy for them to directly get admitted.
Right. Okay. So I'm going to come to the treatment and the treatment challenges, particularly when you have patients with COVID symptoms as well as a kidney failure or a weak kidney. So, Dr. Chanchalani, let me come back to you. So, what is the treatment path that you've been broadly following, and has that changed in the last 45 days? And what are the kind of results that you've been seeing?
See, honestly, initially, COVID is still a puzzle, and there are still many pieces which are missing. Every day we are learning a new treatment which may work. We have new studies which is coming every day. So we are like probably becoming wiser every day. But then there is no direct treatment to the virus. There is no antiviral which can actually kill the virus and turn things around. The very fact that this pandemic has spread is one thing is because of the infectivity, and one thing because we can't kill the virus early. So the patients do remain infective for a long time and they continue infecting. So that is the main worry. So we are mainly doing symptomatic treatment. There are many vitamins which have been found to be, minerals which have been found to be effective. So we use those for mild cases per se. There is no antiviral. I would rather suggest that people could take that at home itself and not report to the hospital, so that we can save the resources for more deserving patients. And for sick patients, again, we do not have anything. Oxygen is probably one thing which helps. Awake toning is another factor which helps oxygenation and opening up the lungs. Patient prone and ask them to lie prone maximum amount of time, open up a bit. We are giving more anticoagulants, a blood thinner, and which is also one factor which is there involved in the pathophysiology of COVID disease. And one another thing is we are using IL-6 inhibitors. IL-6 inhibitors we have found quite positive in our hospital. We are using it quite early, quite on time. If you give it, it really turns around things for us.
Can you come again on that part? You talked about 80 years patients.
This 80-year lady who was like, we kind of, not really maintaining her oxygenation, and the family was not keen on ventilator. So we just used this IL-6 inhibitor and it turned around things because we could give her timely. She reached us timely. So actually what happens in COVID is the virus goes and affects the system such that there is a huge surge of inflammation or the cytokines that are there. So we just cut off those cytokines. We are not per se killing the virus. So when the cytokines are cut, the body probably can heal itself in a better way. And so the oxygenation of this lady improved after the second dose. And today she's sitting up, walking around in our ward. And I'm hoping that she would be discharged in a couple of days.
That's really good to hear, and obviously I do hope there are more such cases. Dr. Lakhani, let me come back to you. So, when a patient is suffering from both, which is a kidney failure or a weak kidney, and showing, let's say, slightly more serious symptoms or moderate symptoms of COVID, are the treatments too strong? Are they able to manage both the problems at the same time? How does it work?
So basically, already as we discussed, chronic kidney disease patients are already immunodeficient. So they're already immunocompromised on all the states. So the milder disease, as she rightly said, the milder patients basically are getting stabilized with just probably vitamin supplements or mild or basic antibiotics what we use. Of course, drugs like hydroxychloroquine, probably azithromycin, and doxycycline we are using for many patients, and ivermectin too. So there are definitely various temporary or short-term studies which are there, which have shown some benefits. These drugs anyways we use on a day-to-day terms. So they are not definitely significantly harmful to patients if given. Definitely we don't have a specific drug except for the IL-6 inhibitors, which we use definitely in our kidney patients also. But when definitely they have either a significant high count, which we document, or they are in a cytokine storm-like picture or a multi-organ failure-like picture. Rest of the dialysis per se treatment remains same, except in a case of acute kidney injury probably, which is specifically to a multi-organ failure or a severe cytokine storm. We have used some patients with SLED, a slow dialysis probably. What is found is this patient requires a lot of anticoagulation. There are a lot of dialysis tubings which are thrombosed or probably which are blocked because of blood clots. So anticoagulation requirement is high in these patients. And there are studies which have shown probably that to send them home also on anticoagulation, which we have not yet started. So probably with time, we'll have to see that also. At present, I think most of the hospitals are using low molecular weight heparin or unfractionated heparin for these patients, which we are doing safe.
Right. Right. Okay. Last couple of questions to both of you, and let me come back to you, Dr. Chanchalani. So, as the cases rise, and which they have been predicted to rise, and we'll have a lifting of lockdown, which is going to obviously make it rise further. How are you gearing yourself? I mean, and what do you see happening?
See, we actually have our hospital quite prepared, but as I said, our main neck or the problem is the manpower resources. So if we can go up on that, the hospital is fully prepared for our friends. We have beds. In fact, even now we are working in a good number of patients. We try to not refuse a few patients, but then we do not have enough capacity to treat them. That's the only problem that we have. So I think the city should probably gear up by small hospitals where if they are not treating COVID, probably they could lend their manpower resources to us so that we could function more beds. Maybe that is what I could expect from the government. We are trying to speak to smaller hospitals around who are actually not very keen on having COVID in their center, because COVID requires a lot of not just manpower, but the cleaning resources, housekeeping resources, many more planning, and everything needs to be done. Not all hospitals are equipped with 2 entries so that you can have a 1 red entry, 1 green entry, or things like that. So you can't make a clear corridor, give a lift to a COVID patient. So these smaller hospitals cannot really function with a COVID and a non-COVID at the same time. So if they are not really functioning, they could lend our manpower resources to us so that we can function in a more stronger way and treat more and more patients. That is what I think would be the only thing which we can expect from hospitals around. But overall, our management has, as I said, has been quite supportive. We have done mock drills. We have our whole contingency plan in place so that even if a patient is transported, the immediate cleaning is done so that within next 20 minutes, anybody passing through the route will not be infected. So all these plans are very much in place and we are quite prepared for that.
Right. Dr. Lakhani?
So basically, as he rightly said, more and more, I think symptomatic patients will have to catch hold of things. There will have to be a triage still, which is still going on. Governments are making a lot of rules, but triage will be required of probably severe patients, probably going out to more bigger hospitals where there are multiple more facilities rather than just quarantine or probably oxygen centers. And milder or asymptomatic patients will have to be shifted to CCC. I think 3 days, they've already come up to a 3-day rule. So probably 3 days will be ideal. You get admitted. If there are no symptoms in 3 days, you can directly shift to either a quarantine or a home quarantine setup. I think with time, when the case numbers are going to increase, we'll need more hospitals, definitely more beds. And as she rightly said, manpower, where and where there are people, those who are quarantined or those who are probably sick also, with time, they'll probably join us in the fight against the COVID. And that is how I think we'll be able to cope up with the limited resources what we have at present.
Right. We're running out of time. So last question to you, Dr. Chanchalani. So what's your advice to people who might be, let's say, maybe seeing the onset of COVID or suspecting that they have COVID or maybe even have tested COVID?
See, I would just say for the common man that please don't panic. COVID is not dangerous. The only thing I would say worry for a common man is COVID has this terminology which is called as happy hypoxia. What happens is actually in this patient who get COVID, it affects only patients who have comorbidities or who are above the age of maybe 50 years of age. Only those patients really worsen. Some young also do worsen. I would not say that they don't, but obesity is also another risk factor. So young people with obesity are more at a risk. So people who are healthy should not bother. Probably just hydrating themselves well, eating well, having a good sleep is good ways to increase your immunity. So that is what they can continue. As I was talking about happy hypoxia, when COVID affects the lungs, the oxygenation of the body drops down and the patient is not aware of it. The patient is still happy thinking everything is normal with me. So that is why this term is called as happy hypoxia. So the point is to catch these patients at the right time so that they can come to the hospital. So for one advice for the common man is when I fall sick, I have this tendency of lying on the bed. Rather, I would tell them, you all please take out 5-10 minutes of your day, walk around in the house in a normal way and see if you're getting breathless. If those 10 minutes or 5 minutes of walk make you breathless, please report to the hospital or don't come to the hospital. Usually you can be treated at home itself. A fever of 3 to 5 days is normal in this COVID. And if the fever extends beyond that, maybe you all can come to the hospital. Otherwise, panicking at the first onset and coming with the first fever probably limits our resources to take more deserving patients.
Right. But anyway, so bottom line is don't worry, watch for a couple of days, check if you're feeling breathless. And also, of course, remember the data is largely in favor of all of us. Not everyone becomes serious. Would that be a fair assumption, fair summation?
Yeah, basically
yes.
breathless on exertion. If you are feeling breathless
Right.
at rest, it's quite late. So exert yourself at home
Right.
also to know if you are breathless.
Right, right. We've run out of time. Thank you so much, Dr. Lakhani and Dr. Chanchalani, for joining me and sharing your insights. I do wish both of you and your colleagues and teams all the very best in this fight against coronavirus. Thank you very much for joining me.
Thank you so much.
Thank you.
And
Thank you so much.
I just want to thank Dr. Siddharth because I came to know about this Project Victory. We will try to also enroll our patients there. Thank you so much.
Definitely.
Wonderful.
Yes. Sure. Thank you so much.
Thank you. Bye.
Thank you.